Correct. بسم الله الرحمن الرحيم الحمد لله رب العالمين والصلاة والسلام على أشرف المرسلين سيدنا محمد وعلى آله وصحبه أجمعين. My name is Sundar Saad, and I'm so excited to be presenting our second event under the Muslim Professionals, Healthcare Professionals Advocacy Network. It's a program under CARE. Our event today has one of the greatest trailblazers in the United States, so I look forward to having you guys join us, inshallah. Today we will have our moderator and three of our panelists. I just want to highlight some of the things about the MPAN, and I hope that we can invite more people actually to join us, inshallah. Of note, this event will be recorded and inshallah will be uploaded to the YouTube channel of the CARE. Muslim Healthcare Professionals Advocacy Network is actually a program under CARE San Francisco Bay Area chapter. And our aim is actually to inform and mobilize those who are working in the biomedical industry towards interactive legislative process. You don't have to have any experience to join us in advocacy work. We want actually to positively impact policymaking process, identify the intersectionality of healthcare and civil rights and Islamic value. We want to build a community of Muslim advocates in the industry. And our strategies at the moment is focusing on building a team of professionals to authentically engage in civic process, focus on local while thinking global, and negate some of the negative feelings towards politics amongst Muslim professionals. I will share the link to the MPAN, and we look forward to having more of you guys join us, inshallah. I do facilitate a program here in the California, and I want you to know that there's actually a chapter in the Ohio State as well, and we're hoping to expand these chapters. So if you are not local to California and you would like to open a chapter, we will help you with the process, inshallah. And I'm so excited to introduce my friend, my sister, my mentor, my support system here in California, soon to be Dr. Muna Bashir. She's a PhD student at the UCSF Institute for Global Health Sciences. She received her master's in maternal child health systems from Bastyr University and her bachelor in biology from University of Texas at Dallas. Muna has helped design and implement evidence-based tools, programs, and services at large birthing facilities to improve patient-provider communication, reduce surgical birth rates, and boost the quality of care. She has a niche in supporting socially vulnerable groups in the United States to overcome past birth trauma and achieve positive birth experiences. She has served on the executive board of PATCH, which is a non-for-profit organization dedicated to the prevention and treatment of traumatic childbirth. She's currently involved with various research projects at UCSF to improve MCH outcomes both locally and globally, and she is an anchor to our Muslim community here in the Bay Area. I will hand the mic to Muna, and I welcome all the attendees, and thank you so much for being here today.
Jazakallah khairan, Sundar. Thank you so much for the kind introduction. Welcome everyone for joining us today for Maternal Mental Health Awareness Month this May. And we are so excited here to have our panelists. And we are really looking forward to sharing and delving into our national standing on this crucial topic. We look forward to exploring current affairs, both domestically and globally today, and their impact on maternal mental health within the healthcare landscape. Without much further ado, I'm going to go ahead and introduce our esteemed panelists today. Dr. Dina Kishawi is a Chicago-based obstetrician gynecologist who has just finished her residency, and I recently learned that she's going to be going to Brown University for a new faculty position. So congratulations, Dr. Dina. She's particularly interested in health outcomes that are unique to Middle Eastern and North African patients residing in the United States. Her research also extends to Muslim patients to ensure they receive medically and religiously appropriate care. With her fluency in the Arabic language, her research with Muslim patients in healthcare, and she is a mother, trauma surgeon, speaker, advocate, and entrepreneur, inspired by the power of individuals to lead the change they seek. At the Defiance Academy, an organization that she has founded, Dr. Hussein helps women break stereotypes, overcome obstacles, and advance their careers without compromising their core values or personal goals. Through personal development courses, workshops, and conferences, she strives to create an environment and community where women are not forced to choose between their values and their aspirations. We're really looking forward to hearing from you, Dr. Khalil Hussain. And last but not least, Dr. Nida Bajwa. She's a family medicine resident physician at UCSF. She's an organizer with Healthcare Workers for Palestine, a national organization that strives for Palestinian liberation, and DPH Must Divest, an abolitionist organization that seeks to remove policing from healthcare. She has a background in journalism and global health studies. We're really looking forward to hearing from you as well, Dr. Nida Bajwa. Without much delay, I think we will go ahead and dive right in. And I have an opening question for our panelists, and then they can each of them can take turns sharing their expertise and their views. My first question to you all is, how do you see your work as advocacy for women's and maternity health? And Dr. Khalil Hussain, maybe we can start with you.
Yes. Assalamu alaikum wa rahmatullahi wa barakatuh. Thank you all for having us and for inviting us, inviting me to this conference. I think it's very important work that you guys are doing, and you guys have my respect and admiration. So how do I see our advocacy in affecting maternal health? I think advocacy is very, very important, and I think it's more important than knowledge and education, right? We can educate the community. We can empower our community through knowing, what to expect during their maternity period, what to expect in the hospital, and just the whole experience of childbirth. But the reality is, no amount of education and no amount of knowledge will protect you from experiencing the disparities that are present in our healthcare system. And so I'll give you a personal example. As a surgeon, having children in a hospital, the experiences that I had in navigating it as a woman, as a Muslim woman, as a Black woman, were things that I should not have expected, right? These are people who knew that I was a physician. These were people who knew that I was a surgical resident while I was having children. And while delivering, I have one set of twins. While delivering my twins, I had to threaten to leave against medical advice, to leave the hospital against medical advice, because the person who was on call, it wasn't my physician, it wasn't my gynecologist. She was away, and I came in as an emergency. I had to deliver in the operating room because there was a risk that I would have to have a C-section because one of my children was breech. And so knowing that I have rights as a patient, she was trying to force a more inexperienced trainee to deliver my high risk pregnancy, my high risk delivery. And so I had to fight, and I had to, really advocate for myself and threaten to leave against medical advice in the middle of labor for me to be heard, for me to be listened to, right? And so no amount of knowledge, no amount of experience, no amount of wealth protects you from the system. And it's through advocacy, it's through self-advocacy that we impact change, and we change the cultures that are harmful to us. And so this is one of the things that we focus on in Defiance Academy. Is it's great to have all this knowledge, it's great to have all this experience. And one of the things that we promote is, yes, we need to have more people from our communities go into medicine, go into these fields, and to educate themselves and to educate the community. But we also have to empower our community with amplifying and using their own voices. Our communities are not voiceless. They have voice. They have a voice. They just need the skills to use that voice to impact and influence the changes that they need to. Dr.
To
Kshavi?
to echo off of Dr. Quali, I think one big aspect of advocacy that we should understand is there's our patients advocating for themselves, and then also physicians, nurses advocating for their patients when they feel like their patients are in situations where they're very vulnerable, such as yourself, Dr. Qali, or in situations where they feel like they're not being heard. And I think part of the responsibility as a doctor or anybody really with some sort of power is understanding where you can advocate for your patients and at what level, but also realizing that sometimes you need to walk your patient, assist your patient through these kinds of conversations so that they can feel the confidence that they need to speak up. Not everybody has the courage to be able to advocate for themselves in these situations. And not everybody has the knowledge to know what they can and what they can't do, what are their rights as a patient. I feel like definitely in our Muslim communities, we see this often where healthcare workers put their stereotypical biases or these preconceived notions and they layer them onto the patient. And unfortunately, the patient either doesn't know that that's what's happening. They're not aware of these decisions that are made on their behalf without even having conversations with the patient. And so we need to do a really good job about educating non-Muslim providers about what our patients need, and then also teaching our community that they can speak up for themselves, that they have rights as a patient, they can ask for, demand certain things as a patient, right? Because at the end of the day, they are the priority, and having that ability is something that they need to speak up for themselves.
Thank you, Dr. Khali Hussain and Dr. Adina Kishavi. And Dr. Nida Bajwa, we'd love to hear your thoughts as well on this question. How do you see your work as advocacy for women's and maternity health?
Yeah, thank you. Thank you for having me. I'm so sorry I was late. I was just dealing with some technical issues. Yeah, it's a great question. I think my perspective might be a little bit different since as a family medicine physician, we take care of people through the process of being pregnant as well as the process of labor and delivery and postpartum period and take care of their child as well and their other children if they have other children. And so what it means to be a woman or what it means to be a mom to me feels like deeply connected to what it means to be a member of a family or a unit or a community. And those sort of building blocks of society exist at many, many levels and are attacked at many levels, right? And so one way in which your rights as a mom and your rights as a woman are threatened is through the practice of family separation or through the practice of questioning who gets to be a mom, who should not be a mom, and how society sort of makes those decisions for people, especially for women of color. And you see that a lot working at a county hospital in a safety net system. We as family medicine residents have to be in the room where we make choices about whether a mom gets to keep her baby. And we feel entitled to make those decisions based on deeply racialized, deeply problematic concepts most of the time. Not to say that, that's present for every single person in the room, but inherently in a society that is racist, anti-Black racism, anti-Muslim racism, we see all of that come out, and we see the judgments that people make, whether they're happening at a subconscious level or not, they come through. And then unfortunately, as a care team, the social worker, the doctor, the nurses can make a decision that they don't feel that this person is fit to be a mother. They don't feel that this family should stay together. And these are decisions that have massive repercussions for the rest of people's lives. And unfortunately is a practice that exists outside of the medical space. It's a system of racism that we also can advocate for outside of our actual clinical care and the practice we provide. When you you know, when you're caring for someone, oftentimes you're realizing that there are policies influencing that person's ability to get the care that they need that are so much bigger than what you're doing in that room. And so trying to, you know, see clearly, think clearly, advocate for what you know is right, acknowledge that there are lenses that people have that are allowing them to see things in, you know, not totally fair ways that are influencing the decisions they're taking. And also realizing that beyond advocating for that person in that room, you also have a responsibility to advocate for women, to advocate for moms in ways that acknowledge the effects of racism, anti-Muslim racism, anti-Black racism in their lives, beyond, you know, your clinical encounters. So when you step outside of those clinical spaces, what, you know, activism, what organizing work can we partake in that supports the idea that, you know, a woman's health is a family's health, is a community's health, is a society's health. And for me right now, you know, I can't do anything without really thinking about Palestine. And when we see, you know, the brazen attacks on pregnant people, on women, on children, on families in Palestine, we also think about when we're in that room with women that, you know, in a micro way, who are experiencing similar things, similar effects of racism in their own lives, how we can draw those connections for ourselves in the moment, for the larger society, for other people in medicine, forcing people to see all issues as connected, and bringing that to the forefront in their own interpersonal work, in their own clinical work, and in the work that they do outside of the clinic to you know, ultimately make a better society.
Thank you so much for sharing those powerful thoughts, Dr. Nida Bajwa. And yeah, you know, this kind of brings me to a portion which was not mentioned earlier, but I've actually had a chance to work as a doula by the bedside of birthing women across the US, Canada, and overseas. And a lot of women I work with are women of color. And at one time I was sharing with one of my mentors, you know, just even the language and cultural barriers. Sometimes they don't know they can speak up, or sometimes they don't understand what's being done, and just the aspect of consent before things were being done. And she said, you know, even women who are proficient in English have a hard time when they're in labor, sometimes comprehending what's going on. So there's so many layers, you know, to this. And with that, you know, I'm coming to my next question for our panelists. How can we address the stigma surrounding mental health and Muslim communities, particularly concerning mothers?
I can speak on this from the perspective of postpartum, either postpartum blues or postpartum depression. I think primarily we as a community don't understand enough about it. We don't know what the signs of, for example, mental health issues are during pregnancy, after pregnancy. So it's difficult for new mothers to be able to identify what's going on with themselves. They might think it's just something wrong with them, and not that there's an actual concerning mental illness that is associated with pregnancy. But also we need to better educate our community about these signs and how we can help and support new mothers. So prime example, I know some of my closest friends actually just delivered this last month, and they're struggling with certain aspects. And a lot of the aunties in the community, their first reaction is, oh, don't worry, it's just because you're sleep deprived, or it's just because you're being woken up all the time by a baby, or because you have to do all of these new responsibilities and you were used to your comfortable life beforehand. And those kinds of comments aren't really supportive, first of all, but they don't really address the larger issue at hand, which is, you know, newly delivered moms are at much greater risk for depression, anxiety, postpartum associated mental illnesses, especially if they've had something beforehand. And putting aside that aspect, as a Muslim community, we often look at depression and anxiety as a lack of faith or a lack of iman, and it causes such a huge taboo for people to speak up, right? So even if they were to address or they were to acknowledge that they had some sort of struggle postpartum, mentioning it for them might be stigmatizing, because they now are concerned about how they'll be viewed within the community or viewed within their family unit, about, oh, being weak, you don't have enough iman, you don't have strong enough faith, and that's why you're, you know, quote unquote, being punished with this. But it's sort of reframing the mentality of what postpartum or what depression and anxiety are in general, but especially what postpartum depression is like. I know we as a community can do a much better job supporting new moms. One of the biggest things I always tell my patients about is for as long as you're in your, NIFAS, your postpartum bleeding period, to sort of speak up for yourself, decline having guests over. This isn't the time to be hosting and serving, and just focus on you and your relationship with the baby, because plenty of research and studies have found that that's the crucial bonding time. And so that could also help decrease our rates of postpartum depression in our community if we can sort of put aside those regular visits from all the community members and the aunties and just focus on mom bonding with her newborn, mom taking care of her family, building this new family unit that she wasn't used to, and then adjusting to the postpartum period, which is incredibly difficult with changes in hormones, changes in your body, also changes in your schedule, especially if you used to have some form of a routine before, and now you especially don't with a newborn that's always, crying or needing to be fed or needing to be changed. So these aspects are contributing to pushing women away from speaking up about their mental health postpartum, but also as a community, we have a long way to go before we can actually become more supportive for new moms.
Thank you for sharing, Dr. Dina. Yeah, Dr. Hussain, please.
Yes. So I think it's a great point about cultural, practices that contribute to this. But I think an important conversation that needs to be had within the Muslim community, we see it especially in our Somali community, is talking about mental health and acknowledging it as a real illness, same as diabetes and high blood pressure, right? It's not a lack of faith, not a lack of iman. And so there's a resource that actually I can point you to everybody listening and whoever watches the recording. There's a podcast that's posted by young Somali women. It's called The Digital Sisterhood. I don't know if you guys have heard of it or not. There's an episode in one of the first, I don't know if it's the first or second season, where a young woman came and talked about suicide. Her mom's suicide. And it was, they did it very beautifully. It was a storytelling kind of podcast where I think it was like multiple parts, where she talked about, how her mom was before, she committed suicide, how normal her life was, everybody could relate to her. And then all of a sudden she died by suicide, by jumping off a building. And the number of young people who have listened to this, both women and men, the conversations that were had within Somali communities, within a lot of Muslim communities, is beyond measure. I mean, that podcast blew up just from that one episode, because they talked about something that was so taboo, but that really, really needed to be talked about. And so this is where it can be really powerful to use mediums like social media, podcasting, a way to reach a lot more people, to have these uncomfortable conversations, but to do it in a way that, we're not lecturing people and telling them this is what you need to know, but we're just sharing stories and connecting with people and connecting with their everyday reality, saying this is not unique. It can happen to anybody. It can happen to you. It can happen to me. And therefore, this is what we can do about it. This is how we can advocate for ourselves. So, I would highly, highly recommend that we share this podcast episode with our Muslim communities. Anybody who hasn't heard it, I mean, it's a very popular podcast, but among the young women, right? But it's the, a little bit older generation that continues to see this as taboo and that doesn't want to have this conversation. But mediums like that really, especially with, TikTok and Instagram, where people are on their phones and seeing it all the time. And so you present it in a way that is digestible and that is understandable and that's relatable, I think will help us have these conversations a little bit more.
Thank you, Dr. Hussain. That was very powerful. Dr. Nida Bajwa, would you like to share any thoughts on this?
Yeah, sure. I think, I'm by us all being here, we're also demonstrating a way in which a barrier and a way in which we can look to a future in which, you know, postpartum depression, the whole range of postpartum diagnoses can perhaps be more normalized and more understood in the Muslim community. And I think a big part of that is whether your providers and whether your clinics and the places that you go for support can speak your language, right? And I don't mean that like literally if you speak Arabic, they can speak Arabic. If you speak Urdu, they can speak Urdu, but that they can speak to you in a way that makes sense to you and highlights how you're thinking about your postpartum period. If there are things that you're, you know, in denial about or that are not, that you're, you know, are either normalized to you or not normalized to you, that they can really meet you where you're at. And sometimes it can be a lot harder for people who don't have experiences in other cultures for those providers to be understanding or be empathetic or not be dismissed by Muslim patients, or really by any patients who belong to any cultural or identity groups that whose belief systems or whose ways of being contradict with the American dominant system, right? And so the more providers you have, the more clinical spaces you have that represent that diversity of identity, and, you know, they don't necessarily, that doesn't necessarily mean accepting like, oh yeah, what you're feeling is totally fine if you think it's fine, but it means acknowledging that you're not crazy for thinking that, you know, you should just be X, Y, and Z. I understand that this is part of the cultural pressure perhaps you're experiencing, or, you know, maybe this is what you're hearing from your Muslim community or from other older moms in your community. Perhaps you're being told that you should just be fine and you should just keep trudging along. But I do think there's a way to both acknowledge and normalize a belief that you might think is inaccurate or wrong or harmful as a provider, to still say it's okay that you think that, and it's okay that you know, you're not crazy for feeling that way. And also, you know, there's a world in which we can get you to feel better. And maybe that means labeling them and maybe it doesn't, right? If they're not ready to hear postpartum depression, or they're not ready to hear, you know, do we have to use those terminologies? I think asking ourselves, sometimes we do, sometimes it's really important. Sometimes we can get that person that help. If they're not willing to accept those terms are triggering to them, we can still get them the help that they need. We can talk about medications, we can talk about therapy. There's so many ways to help a person, even while they're in a state of denial or questioning or, you know, self-growth, without needing to impose our medical brains or our, you know, Western medical frameworks on ways of thinking and believing. We can still offer help and support, and we should always still be there, regardless of where mothers are at, Muslim mothers are at in their process and their journey. And being there, regardless of where they're at, is, I think, just the most important thing. The more people we have, the more providers we have, the more clinical spaces that are unconditionally supportive. You know, you don't have to show up being ready to get that care. That's, I think, the most important thing.
Thank you for sharing that, Dr. Nida Rajwa. Yes, I think, you know, one of the important things is for them to just know that there is someone out there, you know, and there is support. Many times new moms can feel challenged when they feel there is no one to go to, or no one gets, or that can understand them, right? So really important. Thank you so much for sharing those thoughts. How can we ensure that maternal mental health services are accessible to women from diverse socioeconomic backgrounds? I'd love to hear your thoughts on that.
There's a lot of benefit to having these sort of programs or support systems built into places that our patients are already likely to go to. So having them in mosques, in community centers, in, you know, sister gatherings like halaqas or things of that sort, that allow our patients to be able to ask for it and to be able to receive the support and the care that they need in a very accessible manner. So, for example, I work at a federally qualified health center that's located in a very predominantly Muslim community, predominantly Muslim neighborhood of Chicago. And the resources, because of just the sheer location of it being, you know, 2 blocks away from 2 separate mosques, right across the street from a women's community center, having that sort of availability and accessibility makes it very easy for us to point patients to the support that they need. Not saying that now you have to go around and build all of your clinics in geographically suitable locations, but also understanding that you have to meet your patients halfway. So providing support lectures or screenings, things of that sort at the mosques on community days, or in places that these moms are going to frequent, whether it's like picking their kids up from Islamic school on the weekend or the local grocery store, or mentioning it at gatherings. I know some of the mosques in my city have something called chai chat or like tea time, where they bring up topics once a month that are per the request of the community women, and they have an expert in that field talking about it, whether it's things like postpartum depression or things like how to discipline your kids, right? And so when you make that information and you make that support accessible, whether it's having people like Dr. Nida was saying that speak the language, that understand the culture and the religious background of these patients, or you make it in places that are easily accessible and attainable for people to come to, you're definitely going to have that much more support. The other thing I want to add, though, is we live in a society, we live in a country where a majority of the providers, majority of the population aren't Muslim, right? So if you're expecting that these community members can speak up and ask for themselves, and that's great. If they can advocate for themselves, they'll be able to. But to echo Dr. Nida's sentiment, you have to be able to also have providers that identify when our Muslim patients are struggling, and then what are the resources that they can provide them with that are religiously in alignment with the medical care that they're receiving as well. So there's a lot of different things that you can sort of approach and do to help your patients succeed and help your patients reach the best of their health as possible. That would definitely be beneficial.
Thank you for sharing that, Dr. Dina. I'd love to hear any thoughts from Dr. Hussein and Dr. Nida, if you'd like to add to this.
Actually, I do. One other thing, I just saw Dr. Sundus's question about receiving funding. So this is a very big issue for our communities for a lot of reasons. And I know this is eventually going to come up later on, but one of the most predominant reasons is the Arab, the Middle Eastern and North African community, the Arab community, however you want to sort of identify this community, in all of the demographic surveys has historically been labeled as white. And so we receive our funding, and we receive funding for research, we receive funding for community support programs, things of that sort based on grants. And those grants are often awarded based on need. When you're looking at our community compared to other communities of color, Arab communities get classified as white. So technically, in the legal system, in the research system, in the funding and the grant process, we're not actually considered a community of color, and we're not actually considered a community of need because we don't exhibit the same sort of medical problems or necessity as other communities of colors. The problem with that is it's incredibly, incredibly damaging and dangerous for our patients because, especially from the aspect that I could speak on, maternal health, there's a lot of problems that are particularly worse in our communities, like gestational diabetes or cholestasis, that have much greater repercussions on pregnancies and on the postpartum period, and as well on affecting postpartum depression. And so when you have these communities being labeled as white and not being able to receive grant funding, you're now eliminating an entire population that needs that support. And the only people that are going to front those costs are usually our Muslim community, giving zakah, giving sadaqah, giving their charity. And that's not that does not financially support these research endeavors as much as possible. That's not all of the support that we need, right? We need much greater financial support to be able to provide first of all, to be able to understand these communities better, to have better research, but then two, to be able to provide the support. We can't continue to rely on our own Muslim community with their zakat to be able to sort of push the success of our community forward. Part of it does have to come from these larger institutions, whether it's universities, hospital systems, from a state level or from a federal level. But we as a Middle Eastern North African community have been at such a great disadvantage because we have not been able to receive the funding necessary because we don't blend into the demographics of our community. It wasn't actually until very recently that certain states and now on a federal level are using MENA, Middle Eastern North African designation, as a separate demographic identifier. But I mean, from the maternal health perspective, there's a handful of studies that look at Middle Eastern and North African patients, and that's because they had to self identify and they had to select and so forth and so on, that these aren't robust studies that give us a good look at our communities. And part of it is just because we've just been this big conglomerate of white that we have been marginalized for so long. And we have a lot of catching up to do from that regard. But once we're able to show that our communities are in need, which they very much are, then we'd be able to get that funding from a state and a federal level.
Thank you, Dr. Dina. That was really important to share. Would the other panelists like to chime in?
Yeah, I can speak to that a little bit. You know, it really, mental health is just one area that really explicitly highlights what a radical restructuring of our society we need, right? And how deeply incorrect our priorities are as a result of the, social and economic systems in this country that have very differing motives than what would truly help people. And you really struggle working in a federally qualified health center system, as Dr. Dina talked about. I think that everyone sort of knows how hard it is to get mental health care. That's sort of a generally understood idea. But when we say it's hard to get people in San Francisco General Hospital and the Family Health Center, we're a county hospital network that gets funding from the city rather than from the country, but largely operates the same way. When we say that there are like no psychiatrists, like absolutely zero psychiatrists available, it can take 6 to 12 months to get someone connected with a psychiatrist. And that's across the board. That's just to get into the door. So you may not have religious concordance, identity concordance. You may not be able to feel connected to that person. You may not be able to feel like that person can help you. And that's a psychiatrist who's going to give you medications. There's also a therapist, which is incredibly important and is often a completely different role. It's very important that that person understands you. It's very important that you feel safe with them. Oftentimes that requires identity, cultural, racial, religious concordance, because it can be very hard to speak about things that are super personal and deep to you to someone that you don't think is going to understand you or may judge you. And so when we talk about mental health care, it's really just the barrier to getting in the door is immense in this country under our current federal allocation of money for mental health services, and exists at local levels too, in local public health systems. And then once you get in the door, it's a whole nother game of whether that person's actually going to be able to provide you the care that you need. So really, I mean, I think that it has to come, from the structural lens, from the advocacy lens of speaking to what we're seeing as people who work in public health settings, what we're seeing with our patient population in our communities, and how communities of color and marginalized communities across the board who need the care the most are not getting it. And it's really the majority of the population. That is the vast majority of the population. We are living in a majority minority country. Most people belong to one or more marginalized groups. And as a result of any single one of those marginalized positions in society, you're less likely to receive mental health care and significantly more likely to need it. So we have decided only to allocate a service in this country to the people who actually objectively need it the least, which is an absurd thing. And really, I don't see many ways of doing it without that larger piece. I think we strive to do the best we can in our individual spheres of influence by creating those spaces. There's amazing organizations that do the work, and they work really hard to try to get grant funding and to keep themselves going. But I know that each one of them are always just fighting for their survival to keep their doors open. So until it's valued and prioritized as a country, it's really hard to keep fighting tooth and nail for any of these organizations and like amazing community groups that exist to fill in these gaps.
If I could say one thing and then I have to run. So I want to say something about an important thing that you mentioned, Dr. Nida, is the concordance, racial, cultural, religious concordance, and how important that is. There was another conference where I was talking about this, and it was majority non-minority white physicians. And I brought up the importance of concordance. And one of the most common or the most popular responses that I got was offense. Our physicians take offense to the fact that our patients need concordance, need religious, cultural concordance, people who actually understand them. And they take offense to the fact that, well, I'm a good enough physician, I'm able to provide that. And that is a huge misunderstanding and problem within our organizations, talking about organizational support that Dr. Al-Sad was talking about, is we need to the whole diversity, equity, and inclusion conversations that we're having. It's not enough for you to acknowledge that your patients are at higher risk of these problems and they are experiencing health inequities, but the response to that, the fix for that, is not for you to say, okay, well, I'm not racist, I'm aware, right? These implicit bias trainings have not done anything. In fact, some of them have actually gotten more biased with the implicit bias training. What we need to enforce is the fact that our patients need somebody who understands them. And unless you're willing to do that extra work of sitting there and actually listening to your patients, you need to be able to provide a safe working environment for the physicians that are from these diverse backgrounds, because that's another whole conversation that needs to be had. Is we recruit these physicians from diverse backgrounds, but the workplace continues to be hostile and we can't retain them, right? And so in trying to serve our diverse patient population, we need to fix our workplace cultures for these diverse physicians to come in so that they can be in a position to provide the care that these communities need. So we're not only fighting in getting our patients access to that culturally appropriate and responsive care, we're also having a hard time making our workplaces a welcoming place for these diverse physicians. So there's a huge other thing that we have to deal with from the workforce diversification point of view as well. And I have to go to the operating room.
Thank you so much, Dr. Hussain, for participating today.
Thank you guys for having me. Assalamu alaikum.
Walaikum assalam. So we have brought up accessibility and barrier issues. And with that, I'm going to throw in another question for our panelists here. What is the importance of involving partners and fathers in maternal and mental health support programs?
I'll speak to this from the prenatal aspect into the postpartum period. One of the things I notice is that women who have their husbands present with them at prenatal appointments just feel a greater sense of comfort in that, one, their partner is there, can understand what they're going through, what they're experiencing, is there for a very tumultuous period of their health, and can witness all of the changes, any new diagnoses that come up, and really can be a second set of ears for her when she's in these appointments if she doesn't understand something or if she wasn't really grasping what was going on. And then he's also there from an aspect of support where he can speak up for her, ask questions that she might be too nervous to ask. And having that support system really early on in the pregnancy definitely lays the foundation for how it's going to be in the postpartum period. Research has shown time and time again that people who have a partner, whether it's their father or somebody whether it's the father of the baby or like another family member that's with them consistently throughout the pregnancy and then in the postpartum period, these patients tend to have much greater rates of satisfaction with the pregnancy and the birth. They view their birth as a positive experience, and then they have lower rates of postpartum depression, postpartum mental health diagnoses, and there are fewer hospital readmits for other purposes like blood pressure issues or infections and things of that sort. And this just goes to show that your mental health is tied to your physical health, right? When you're at peace, when you're feeling safe, when you're feeling protected and comfortable because your husband is with you at your appointments or with you during the delivery and things of that sort, you tend to have much better outcomes in the grand scheme of things. So something that might seem just like a very small investment at the beginning seems to have much greater repercussions in a positive manner down the line. And now looking at this from how can we approach our communities to be able to offer and really destigmatize involvement of men in our women's healthcare. One of the things that we seem to notice from a more conservative cultural aspect is women tend to gatekeep their health and their health problems. They don't want to be a burden on their family. They don't want to be a burden on their husband. They also want to present themselves as these very strong women who don't need any support. But that ends up being a double-edged sword because when they do that, they show to the family, the surrounding community, whether it's their husbands or not, maybe sometimes their in-laws or their own family, that they don't need the assistance, they don't need the support. I know one thing that I joke around about this with my friends all the time, but usually on the first couple of days of Ramadan, the lecture between Tarawih at my local masjid is always a lecture at the husbands to be a little bit more patient with their wives because, we're all hangry, we're all struggling, we're all getting adjusted to the new month of Ramadan, the nuances of fasting and now continuing your work, whether it's work around the house or cooking and things of that sort. And we talk about how when you really want to get a point across to the Muslim community, you can do it in Jama'ah, Salat al-Jama'ah, and Friday prayers. You can do it at these lectures. You can do it, during prayers, because that's when you can open the door to these kinds of conversations and you can make it seem like it's really not targeted. This is just a general conversation that we want to have with the community, talking about the struggles that our Muslim women are facing during Ramadan, or if we were to apply this to pregnancy, our struggles that Muslim women are facing during pregnancy, and how as a husband this is your obligation and this is your duty to support. And I think that's really the easiest sort of entryway to even opening these conversations, destigmatizing these conversations and allowing the community to start talking about it within themselves, is if you have your sheikh talk about it on a random Friday afternoon for Jama'ah or at a local lecture, that really does start to open up the possibility of offering support either programs or conversations that are definitely needed and very much missing from our community.
Thank you for sharing that, Dr. Dina. Dr. Nida, would you like to chime in on this topic?
I think what I'll add is I think just the importance of finding safe workspaces and also advocating for fair work practices. Ultimately, your partner's ability to support you will, for most people, largely depend on their employer's willingness to support them, to support you. And so thinking about what institutions both of you are employed in and how much those institutions' policies support family leave and partner leave, not just maternal leave, seeing the family as a unit as a whole, and how long those leaves are, and advocating for yourself and for everyone who comes after you for those practices to be fairer. And, at a federal level, America is the only, quote, developed country in the world that does not offer mandatory family leave. And so this is like an exceptionally, difficult place to be pregnant and to be postpartum. And I think we often don't think about that when we think about the vast majority of the world being a place that was exploited, and thinking that perhaps there it would be so much harder. And in many ways, I acknowledge that it is, depending on where you live, but also that the policies here are archaic. They're archaic, and it's important not to think, well, I am so grateful to be here to be in America, and they're so advanced or so progressive or whatever, some of the myths that we are fed, and thinking that whatever I get, I just have to take it, or that it's not possible to get more, just knowing that it's actually very unusual not to have guaranteed 3 to 6 months at minimum after birth of a child for both partners to be guaranteed time off of work. And so those are your rights. Those are things that should be your rights, even if they're not federally guaranteed, and asking for them, feeling empowered to do so.
Thank you so much, Dr. Nida, for bringing that up. Actually, that's something that I had personally noted, having worked extensively on both sides of the border, like in the US and in Canada. And whereas people there, we would get 1 year maternity leave, over here, like, within 8 weeks, moms are back at work full time. And just the sharp contrast with, within the same continent. Very important points. Thank you so much for bringing that up. Another question, and I know this came up earlier, Dr. Dina had kind of touched upon this briefly. What are your thoughts about the MENA category addition in the current geopolitical affairs?
So as I mentioned earlier, it's something that's definitely been lacking. We as the Middle Eastern North African community have not been represented properly over the last few decades. There's actually a huge historical context about how we even became white in the first place. In the early 1900s, it was much easier to get your immigration status and to get your American citizenship if you were considered white. And so I want to say it was a Syrian community in Georgia. It was the first, either Georgia or Alabama, but definitely somewhere in the South, proposed that we as Middle Eastern North Africans are actually white and we're closer to the Caucasus than we are to Asia. And so therefore we should be identified as white. And this is mostly coming at a time where there was a lot of anti-Asian sentiment. I want you to think back to the early 1900s, between 1900 and 1940s. So this push ended up being what advocated at that time for Arab communities to be listed as white in the census. And it definitely did obviously provide some benefit because they were able to get their citizenships much sooner. They were able to become, voting members of American society. They were able to feel a lot more integrated into the community. But we didn't understand the repercussions of that policy change until the 1970s and the 1980s, when we were having a much greater influx of Middle Eastern North African communities into the United States. And then when they started to become much greater contributing members of society, either by working or just because of our sheer population, right? And then we really saw the effects of how poor that policy was in our community post 9/11. There's one research study that came actually out of California that talked about the rates of preterm labor in Middle Eastern North African communities because of the Islamophobia and the racism that they felt after 9/11. And their patient size, their subject size was so low compared to other nationally garnered studies because they just didn't have any way of gathering all of this information appropriately without patients having to identify themselves as Middle Eastern North African. And it wasn't something, I think in one of the things that the study wrote about was how they also assumed, if there was an Arabic sounding name, that these people are from the MENA category. And that's obviously not the way that we should be producing our research, but brought to the point that we don't have any way of looking at our communities in a much greater depth in terms of research, either from the maternal health aspect, from heart disease, things that affect our community at much greater rates, consanguinity and genetic issues that we see just because of some cultural aspects. But then when you look at the Middle East, these studies are obviously much more proportionate to their population because they don't have to worry about those demographic identifiers. And so it's definitely about time. And this is something that we should have, looked into decades and eons ago. But when the first push to get it on the census happened during the Obama era, we were making a lot of progress. And then after the 2016 election, we took, hundreds of steps backward because of the administration at the time. And now we're sort of crawling our way back forward. Fortunately, we are now as a category on the upcoming census. And I know in the state of Illinois, I want to say it was 2021 or 2022, really pushed for this, especially because of COVID data. And we wanted to see how MENA populations were disproportionately affected by COVID. But the issue is, at least in Illinois, it sort of came a little bit too late when we were looking at COVID studies, because majority of the population in our MENA communities have already identified as white, and then you change the demographic identifier midway through your research, and then now you have a small subset of people who are identifying as MENA. And so from that aspect, obviously, we're making strides, we're moving forward, definitely a step in the right direction. The other thing to consider is, given today's political climate, there are certain demographics that wish to be identified as MENA to really hammer the fact that their location in the Middle East is something that to them is their right, or that they fit in, but they obviously don't have the same cultural, the same religious confines that are shaping our health. And they also just don't have the same genetic background that we do historically that also affects our health. And in particular, I'm talking about more so Israeli communities having much greater rates of skin cancer, right? Because they're from the Caucasus originally. And then when you compare them to Middle Eastern, North African communities in that area, we don't have the same rates of melanoma or other skin cancers, because genetically and through Darwinism and through evolution, we have just adapted much better to living in those environments where the sun is constantly out, the temperatures are much greater. So things like that are just these small nuances that you see on a much greater scale when you look at how demographic identifiers actually impact research and sort of what the implications are about having proper identification for communities.
Thank you so much for sharing that, Dr. Tina. Dr. Nida, did you have anything to add regarding this category?
Yeah, I definitely don't know nearly as much about this as Dina does, so that was incredible knowledge that I just gained too. I think, I think what I'll say about this in a larger sense is that I think erasure is a spectrum, right? It starts at a nominal erasure, a verbal erasure, and progresses all the way to like a literal erasure, population erasure, and that it can be important to, as a step in combating that erasure, just to be able to correctly identify, right? If that matters to that person, and some may choose not to, out of fear of how that categorization can be used for profiling, which it certainly will, and as a way to have a database of, people that will be suspected more than other census groups. However, that step of having that option to see your identity, just to literally look at a screen and say, oh, what am I? And you get to choose something that actually represents you. I think it's an important step. I think also that it's important just to acknowledge, I think I learned about the sort of creation of the racial categories in college, and I remember being alarmed that it was just like one white European man's dream. Like he just thought it up one day. It was like, there are 3 racial categories. There are the whites, there are the this, and there are the that, and it was completely ascientific. There was no basis in the creation of racial categories. And when people talk about how race is a social construct, that's what they mean, that the categories that we have to choose from are completely made up by white men, and just a handful of white men. So remembering that, having that racial categorization, those options are inherently European. And when we see this sort of European desire again to, put themselves in categories where they don't actually align with the population, you see again how we have to continuously reclaim our identities and make a push for these categorizations to actually more accurately reflect society, while also being, appropriately wary, I think, of the ways that categorization on a federal level can be used against us. So I think it's a double-edged sword, having that opportunity for classification and categorization, but ultimately the opportunity for a step away from erasure feels important.
Thank you so much for sharing that perspective, Dr. Nida. Like many things in healthcare, like many tools, like you mentioned, it can be a double-edged sword. So, kind of consciously and mindfully moving forward with these aspects. One last question before we switch to Q&A. What policy changes do you believe are necessary to improve maternal mental health support systems on a national level?
I just want to I want to mention a couple of things in terms of policy, both from somebody who is very familiar with writing policy, submitting policy, getting it approved, passing resolutions, things of that sort. So I'm a member of the American Medical Association. I have been since I was a early medical student. And what I've come to learn through my experience with the AMA is that a lot of the policies that get pushed forward into legislation come from communities where there's a substantial amount of financial incentive and benefit and tax. So these advocacy committees or communities that are financially funding lobbyists that help push their agenda forward. And I bring that up because up until 2021, there had never been any policy that looked at wearing hijab, both from a patient perspective, but then from a medical provider perspective in the operating room. And this is, incredibly dated and archaic if you come to think of it, given that the Muslim population is the fastest growing population in the world, but also we are the third largest population in the US. We're the fastest growing religion in the United States. And we have 5 cities where we are such a huge hub that we have the ability to change policy on a state level, but even now on a much larger federal level. So in 2021, with the assistance of the American Medical Association, I actually wrote a resolution to bring forth policies that allow patients and doctors to be able to wear hijab in the operating room. And the reason that this, even looking back at it, but now is so critical is because we never had anything that explicitly allowed hijab to be worn in the operating room, which meant, to Nida's point, that you don't have any of that kind of stuff. You are entirely erasing a community that could be of great benefit to our patients, right? If you're not allowing women who wear hijab to enter the operating room, as physicians, you're either forcing them to do one of 2 things: to change their career so they never have to step foot in an operating room, or on the second thing, to change their hijab so that their hijab blends more into the either the university, the hospital culture that's acceptable. Either they wear it as a turban, or they take off their hijab and they just wear a bouffant, or they wear a scrub cap like what some of their male colleagues might wear. And so by pushing forward that policy, getting the AMA support to push that policy, we were able to bring that onto a much larger federal level, talk to medical schools, talk to universities and hospitals all across the nation to be able to ensure that there is something for Muslim patients, right? We have an alternative so that they don't have to take off their hijab, they can express their Islamic identity, stay in alignment with who they are. But then on the flip side, our providers can now wear hijab without having to marginalize their identity. That's just one of the aspects sort of the positive impact of advocacy. On the same vein, we, with the help of the American Medical Association, a handful of my colleagues and I were able to push forward getting MENA as a national demographic identifier in healthcare surveys and in healthcare research. So in 2022, at the annual meeting for the American Medical Association, we presented forward this policy, which was ensuring that hospital systems, universities, anybody that was going to deal with medical systems, be it urgent cares, clinics, what have you, has an identity category for Middle East or North African, so that we could look at their data, we could look at their healthcare, we could look at these diseases that are predominant in these communities and use that to shape medications, treatment regimens, initiatives, support programs from here on forward. And again, with the help of the AMA, who's an incredibly strong lobbying organization in the United States, we were able to get that resolution passed in 2022. And it's now one of the sort of hallmarks for how the White House was able to incorporate this into our more recent national demographic identification. And, I'm not saying that the AMA doesn't have its faults. There's definitely a lot of problems with the American Medical Association, but using these large organizations that have the ability and the strength to change policy on a federal level is really important, right? We need to know which networks we can tap into to make meaningful change for our communities, instead of just staying, each in our own island, working on our own communities, but also, our ultimate goal should be improving the healthcare of all Americans nationwide with what's best for all of them. And that does involve then looking at our community on a more individual level so that they don't get marginalized either because of their color or their religion.
Thank you so much, Dr. Dina, for sharing that and for your important work in the field. Dr. Nida, would you like to add anything?
Yeah, I think I spoke to this a little bit earlier. For me, I think the individual policies are important insofar as they lead to a restructuring of the societal priorities. And so I think while folks are doing this incredible work on the ground that Dina spoke to, my personal focus has been largely in ensuring that those policy changes are in alignment with larger and holding governments to account that those policy changes are in line with a ultimate goal. So the ultimate goal always has to be that, for me, universal healthcare has to be the goal. And as we are increasing our funding for mental health supports, for increased services in different avenues, we're slowly building that those are the building blocks to a different way of approaching healthcare altogether, and that sort of light at the end of the tunnel remains, so that we can feel sure that there will be a day where we're not fighting tooth and nail to get someone, a basic medical service, or where they have to be uninsured for months at a time, or where they could lose access to life-saving medications because they simply can't afford them. Without that sort of larger restructuring, the smaller changes will always be sort of fragile and potentially be taken away. And for me, I think about the ways in which providers can be advocates for universal healthcare as an ultimate goal, both for ourselves so that we don't have to be fighting up against incredible barriers every time we try to do anything, but also for the patient so that healthcare doesn't have to be such a difficult and profound thing to access.
Thank you so much, Dr. Nida. I think we have our first question here for Dr. Dina. How can junior faculty and students connect with you to participate in your advocacy work at the AMA?
You can send me an email directly at dina.kashawi@gmail.com, or you can reach out to me on Twitter. The upcoming AMA meeting is in 2 weeks, actually. And for those of you who are AMA members, the conference is for free. Especially if you're based in Chicago, it's a really convenient opportunity. But putting that aside, if you want to get involved on the medical advocacy aspect, I would highly recommend being a member of the AMA. Despite the qualms that we might have with it, that is the body of power, the largest body of organized medicine, and body that does shape legislation in the United States. So I would recommend, if you're not already a member of the American Medical Association, joining. A lot of independent medical colleges, like the American College of Obstetrics and Gynecology, for example, offers free AMA membership as a part of their college membership. So that would be your first step. And then even on a state level, any of your medical societies on a smaller state level are a good way to get your foot in the door in terms of working with advocacy. And then, if you reach out to me, I'd be more than happy to connect you to, figure out what your goals are and how to get you there in terms of the advocacy aspect, because I think it's really important for us to show up in these rooms. They often say, I think that the saying is like, the squeaky cart makes the loudest noise or something like that. But really, the way that policy is changed is by having a voice and making sure that you're in those rooms when, on that table when those decisions are being made. And the only way that you can do that is getting involved in these kinds of organizations from a grassroots level. So I would be more than happy to help connect anybody who's interested. You can reach out to me. Dr. Sundis just wrote it in the chat section. But you can also reach out via email. It's firstname.lastname@gmail. So dina.kashawi@gmail.com.
Thank you so much, Dr. Dina. with that, I think we can switch over to our Q&A. If are there any questions that participants would like to share in the chat? And this recording will be shared with those who registered for the event. Sundus, would you like to mention, like, are there any logistics regarding sharing of this recording? Would it be going to the email of those who had registered? Or is it upon request? I don't see any Q&A.
Yes, inshallah, the recording will be shared with everyone, and we should be able to hopefully post it on the YouTube for the care. Also, stay tuned because we will be having another event in August for policy training and advocacy training. And also, we will be sending a debriefing of this wonderful webinar. It was very hard to keep up with all the speakers' great points and action items. So maybe like if our speakers can give some sort of a one recommendations for one action item for all of us. A lot of biomedical professionals and students, by the way, that are attending, and those who have registered are directly involved in the biomedical industry. So here's what I recommend you do now in the next week, in the next 24 hours, and the next hour would be really great from our speakers. And I can't thank you enough for everyone, our wonderful moderator and our speakers who have volunteered their time today and given back to the community over their past career life. And I look forward to crossing paths with you in person, online, and hopefully in the hereafter when true justice can be implemented, inshallah, and peace can be really real. Jazakallah khairan for your posts. And I think everybody wants their time back. So maybe like throw your last gym in and we look forward to hosting you for more events, hopefully in person in the beautiful Bay Area. Jazakallah khairan.
Thank you so much, Dr. Sindus, for putting this together, and soon to be Dr. Muna. We appreciate it. Thanks for hosting this.
Jazakumullah khairan. Would you like to add any final gem before we wrap up?
I think, this is a great step for those who are in attendance. This is really the first stepping stone to getting involved in advocacy, either on a local or a national level. And really, I hope everybody takes something from this and uses it in the future as some sort of impetus for change, because it's, we are able to make a difference as long as our voices are out there.
Thank you, Dr.
Thank
Dina.
you all. I think the last thing I'll say is I didn't actually speak to it too much in answering the questions, but the bulk of the work I've been involved in the last 6 or 7 months has been in organizing a national group called the Healthcare Workers for Palestine, which has a chapter here in the Bay Area and chapters around the country. And I think if anyone is looking to do something now, that would be the avenue I would, most strongly recommend, given the urgency and given how Palestine is an avenue in, Palestine work is an avenue into all organizing and social justice work. So I think if anyone is interested, they can reach out to me. I can put my email address in the chat, and you can find us on all the social medias.
Thank you, Dr. Nida. And I think with that, we can probably wrap it up for this event. I don't think there's any other questions. Jazakumullahu khairan to the panelists for being here today. Jazakallahu khairan, Sundus, for helping organize this. I wish you all a wonderful rest of your weekend. And with that, we'll end with Surah Al-Asr. وَالْعَصْرِ إِنَّ الْإِنسَانَ لَفِي خُسْرٍ إِلَّا الَّذِينَ آمَنوا وَعَمِلُوا الصَّالِحَاتِ وَتَوَاصَوْا بِالْحَقِّ وَتَوَاصَوْا بِالصَّبْرِ. Assalamu alaikum wa rahmatullahi wa barakatuh.